Hello everyone, welcome back. I hope you're all doing super well. My name is Karan, and today we're going to be talking about dementia. So, what is dementia? Dementia is defined as a progressive, non-reversible decline of intellect and global cognitive function without decline in consciousness. Well, what does this mean? It basically means that they lose or gradually lose their ability to perform certain tasks, and you see a global decline in their intellectual capacity, but then they are still able to, or they're still as conscious or as awake as they usually are. This contrasts to something like delirium, where you have fluctuating levels of consciousness with a similar decline in intellect and global cognitive function. So, making that distinction between dementia and delirium is quite important. It's also important to know that delirium often is in the acute setting and has, in most cases, a reversible cause or a trigger. This can be anything ranging from infections to electrolyte imbalances, new medications, or just a new environment. Now, very commonly, you might be asked a question about, well, what causes the condition? And with dementia, for a second, humor me, and let's say we had no clue, absolutely no clue what was going on. We could probably make some stuff up and say that, look, there's probably some genetics and there's probably some environmental conditions, and there are probably some faulty proteins at play, which is your pretty stock standard response, right? And on the next page, we have the official definition of the cause or etiology of dementia, which states, among the various causes, there is considerable overlap of clinical and pathological features. Most cases are associated with the accumulation of abnormal or misfolded proteins in specific neurons associated with neuron degeneration. Basically what we said earlier, but just in a more complex way. There are 4 types of dementia that you need to know. The most common one that you'll be coming across would be Alzheimer's dementia. We also have vascular dementia, dementia with Lewy body or Lewy body dementia, and frontotemporal dementia. There's also a bit of a classification system based on where the lesions typically are, but we'll be sticking to these 4 for today. So this is, I guess, the diseases associated with dementia. They're not quite dementia. So you have Pick's disease, and this is quite location specific, and it's called lobar sclerosis. You have Creutzfeldt-Jakob disease, mad cow disease affecting the cerebrum and cerebellum, as well as multi-infarct dementia that's often due to lacunar strokes. So what is Alzheimer's dementia? Well, Alzheimer's dementia, as the name suggests, is a type of dementia typically seen in older patients. What's important to know, and this comes up in pathology a lot, is what are the misfolded proteins called, and how does the pathology relate to the clinical presentation? Now, we have these things called plaques, and that's usually of amyloid protein, beta amyloid protein. And you also have these things called perinuclear neurofibrillary tangles, which can be seen here. And these are often made of a protein called tau proteins. Now, that's important because it comes up in a few places. Because of this tangle, you lose effectively neurons and synapses, and over time, this causes cerebral atrophy. As you can see here, here's a 3D reconstruction. As you can see, the sulci and the gyri are now quite apart, and you can see very clearly an atrophied cerebrum. What's also relevant is that you often notice these changes way before you have any clinical manifestations of the disease. And we usually say that it takes about 25 years from the first onset of microscopic changes to the presence of clinical signs. Now, what are these clinical signs? It's important to know that when we talk about features of Alzheimer's, these are usually very gradual and will be noticed way before the patient's family. So the patient is very rarely aware that they are having this global decline in intellect and cognitive capacity. So a few key domains that are affected include memory, executive function, as well as visuospatial function. So with memory, this starts off with, I guess, smaller tasks. They should be more forgetful, missing items of grocery lists. They forget if they turn the stove off or not. They might forget that they had a conversation with someone a while back, and then that is often quite progressive and may even lead to things like not recognizing or not being able to recognize your own children. We talk about the side of medicine a lot, but as you can imagine, that is a very, very, very debilitating, both for the patient and for their family. Imagine a conversation with your mother, and to her, you are a complete stranger. That's quite devastating, and therefore the impact of a lot of these dementias is really, really severe. And it's important you consider that when you talk to patients and their families. When talking about executive function, so this is kind of the complex tasks you usually are able to do in your day-to-day life. So this includes things like solving problems, conflict resolution, being able to manage bills, basic math, calculations, that kind of stuff. Then with visual spatial stuff, it's usually a later manifestation of the disease. They might have difficulty remembering, so issues with driving, they can't remember their usual routes. They have issues walking around the house. If they reach out to grab something, they might often shoot past that object. And that's all to do with neurocoordinative function. On the right here, we also have a picture demonstrating cerebral atrophy, where you can see you have widening of the sulci, enlargement of the ventricles, and that may cause kind of a pseudo hydrocephalus, sorry, that's the word, hydrocephalus, where we have increased levels of CSF, but not because there's something pushing on it, it's just because everything else around it has shrunk, pulling the lateral ventricles into a larger than normal size. As far as treatment is concerned, as we talked about, the issue is that of neurons and synapses. So we want to maximize the conduction between synapses wherever possible. And this is typically done by two medications. The first one is a cholinesterase inhibitor. The one we use is donepezil. And it acts, obviously, by inhibiting the effect of cholinesterase. You have acetylcholine existing in the synapses for longer periods of time. And this is going to cause higher concentrations and therefore better conduction. And it's been shown to slow the progression of Alzheimer's, especially used in mild to moderate disease. The next agent we have is something called an NMDA antagonist, which, as the name suggests, inhibits the action of NMDA receptors. I don't entirely understand how that happens or how that corresponds to their symptoms, but I don't think that's particularly high yield. And what you need to know is that the NMDA antagonist we talk about is memantine, and that's typically reserved for severe Alzheimer's disease. Next, moving on to Lewy body dementia. Now, Lewy body dementia has a lot of corresponding features with Parkinson's. We have effects on the basal ganglia, and that's important to talk about. What's important to also know is that they often present with impaired attention as well as visual spatial activity. So predominantly frontal lobe signs, right? It's called Lewy body because you see these Lewy bodies, I assume named after someone called Lewy. And these bodies are composed of alpha-synuclein and ubiquitin. Because you start depositing these proteins, you're obviously going to inhibit or reduce the function of the primary tissues around them. And that's going to be obviously detrimental. Next, we have vascular dementia. Now, as the name suggests, vascular dementia is because of something vascular or blood related. It's not really a dementia. It's kind of a secondary dementia, and basically refers to the changes in personality, speech, global function, and intellect following strokes or vascular events. Now, this can be after a single stroke and they deteriorate quite significantly, but the typical case is that you have a person who has one stroke and then they are at a high risk of having another and many strokes. What's important to know about vascular dementia that's different from other dementias is that the decline is very stepwise. What I mean by this is they might have months of kind of stable activity, and then they suddenly over days drop. And then again, months of stable and then drop again and stable, versus our other dementias like Alzheimer's, which tend to have more so a curve-like gradual decline, and it's not step-like. Lastly, we have frontotemporal dementia. Now, frontotemporal is one of the rarest forms of dementia, and it's, as the name suggests, characterized by degeneration that's limited to the frontal and temporal lobes. In terms of histopathology, it's very similar to Alzheimer's because we have similarly a deposition of tau proteins, but unlike Alzheimer's, this deposition is primarily limited to the frontotemporal lobes. in terms of how it presents, two things that set it apart. Because it's frontotemporal, it's going to affect things like speech, personality, and behaviors way before it affects things like memory. And this is quite typical. So when you do fourth year psych, you would talk quite a bit about how personality changes are one of the biggest indicators of frontotemporal dementia, on the earliest ones as well. And the second point being that the median age of onset is significantly lower than that of Alzheimer's. Alzheimer's typically presents in the 60s, 50s, 60s, and onwards, versus frontotemporal that usually presents at a younger age. And the prognosis is not the best. It's about 3 to 5 years from the onset of symptoms. And that's all we had for dementias. I hope that made sense. If you have any questions, as always, chuck me a message or an email. And as always, please look after yourself and please look after your loved ones.